surgery is no major rocket science, or allow you to register that there is no pedestal that a surgeon stands on. It's just about another form of art. So the way you would probably use a different brush to make a different painting, the size of the bristles, the size of the brush, because you are the artist and you know what's going to give you the right stroke that you want. So that's precisely what all these tools are. They're a component of our armamentarium. I do not want to belittle any particular form, whether it's open versus minimal access, laparoscopy versus thoracoscopy versus robotic. However, you have to register what is indicated at that point, what it's the end outcome that is of importance. At no point, just because you have a specific tool you're keen on using, do you compromise the clearance of a disease or the management of a disease. So fortunately, I am trained in all these forms. Like we've started out in our training years with open surgery. We went on to minimal access, laparoscopy, thoracoscopy, now robotic. So I definitely appreciate the improvement in technology. And I think all of us should. I think it's because of that you and me are sitting and chatting miles apart. But as you have technology improvements in every field, we have them in surgery. And robotic is one of the superior technologies that is available. And it has its zones of indication. Robotic is preferred for precision surgery in deeper cavities, and definitely makes it a more comfortable zone. It's like I could travel from Bombay to Pune, right, like in a Volvo, in an ST bus, or in my personal vehicle. And even the choice of vehicle could be between a basic car to a Merc or a Beamer. So the point is, it's the destination that you have to get at, and your comfort zone. And of course, like the reason I give this example is because all technology definitely comes at a price. So I do not want to make people feel that just because they can't afford it, they're getting compromised treatment. Treatment is not compromised. The technique is a little bit more efficient when you use robotic and minimal access, and they definitely have additional costs and overheads that come along with it. Usually, if I used to just give a rule of thumb, kind of, early stage cancers, and solid tumors are the two key points that are primarily the treatment modality is surgery. Largely, treatment for cancer is always a multidisciplinary approach. And the three commonest modes of treatment in cancer are surgical, medical oncology, which is chemotherapy, and radiation oncology, which is radiotherapy. So we normally tend to run a multidisciplinary tumor board or a meeting where we weigh out the pros and cons of all the reports that are there, stage the disease, and then tailor make a treatment protocol for each individual patient. In that, the role of surgery is either upfront when you have a very early stage solid tumor, or it could be sequenced after neoadjuvant chemotherapy, where you shrink the size of the tumor to bring it to a far more functionally acceptable surgical treatment. Because today the focus is also on overall survival, definitely, but more so thrust is being given on quality of life. The last thing I want is someone to live to 100 and curse me for having stretched the remaining 10 years of his life. So functional outcome is very important. So with that, when we use this multidisciplinary approach, we're able to time chemotherapy, radiation in such a way that even though we are dealing with a solid tumor that indicates surgery, we could time it such that the quantum of resection required is smaller and the final functional outcome is better. So it preserves quality of life. Coming to the second aspect of your question was what's the difference between general surgeons and oncosurgeons? Believe me, all surgeons are good. Everybody has, when you do surgery, you reach a point where you've cultivated a skill. Like I said, it's an art form. So you've cultivated a skill and are proficient in doing the same. It is more a matter of the way you view the entire case. So an oncosurgeon has a different perspective that he looks at. Like I said, we would not just focus on removal of an organ as a part of oncosurgery. You are going to focus on how is this patient going to be treated over the next few months to get the best survival and functional outcome. So when we look at disease, we don't want to only remove the tumor, we want adequate margins around it. The concept of what is adequate margins is the perspective that an oncosurgeon adds to the treatment of the disease. The last thing I want is a compromised margin that leads to a higher propensity of the disease coming back. Am I justified? Sometimes it's like when you've got a hammer in your hand, everything looks like a nail. So I might want to just chop, and that's I'm leaking the cat out of the bag here. But oncosurgeons have this very convenient zone of, if you remove too little, you were being very precious and preserving the best for functional outcome, and if you remove too much, you were being very radical. So both ways, you're right. So let's understand that perspective of what is right for which case and which patient is what we train in oncosurgery, and that bird's eye view to overall management of the case is the added advantage of an oncosurgeon over a general surgeon.